Thank you, Chairman, for the opportunity to present our research. Thanks for staying. I want to present what I think is a big problem. There's a large challenge to drug development in Crohn's disease now. That's a clear and present danger to the provision of important drugs for our patients. And this is an analysis of a short-term tactic to help address that problem. So I'll present our findings on the evaluation of the properties of a candidate patient-reported outcomes for use in randomized controlled trials in Crohn's disease. My disclosures. So let's start with a story. So nearly 40 years ago, the Crohn's Disease Activity Index was developed by regressing physician-determined variables, which included both symptoms, physical exam findings, signs such as fever, and others, up to 18 variables, on a physician's global assessment of the patient's severity of illness. From that, 8 general categories were determined which best correlated with a physician's global assessment. From this, the Crohn's Disease Activity Index was born. It was used in the National Crohn's Cooperative Disease Study, evaluated to be modified, then kept the same. And you can see here, this is a composite index. As I mentioned, it's including a patient-reported stool pattern, using terms such as the number of liquid stools on average over 7 days, the average abdominal pain, using a 4-point scale in a patient, general well-being, complications such as extraintestinal manifestations of IBD, findings of an abdominal mass on exam, and findings such as anemia and weight changes. Now, what's wrong with the CDAI? We propose that the CDAI is both subjective and nonspecific. Particularly, it does not correlate well with other objective findings of Crohn's disease inflammation, such as endoscopy. It can be nonspecific and elevated in conditions such as irritable bowel syndrome. In addition, its use as an entry criterion in clinical trials has been associated with high placebo rates. For example, the ENACT trials had placebo rates greater than 40%, and the PRECISE trials had placebo rates greater than 30%. It's not useful as an evaluation of other findings such as fistula or postoperative Crohn's disease recurrence, and there are likely alternatives that exist that are more specific for the evaluation of inflammation. Specifically here, though, this is not a validated patient-reported outcome. Now, why is that important? Well, it's important because this is a large barrier in the current setting of FDA guidance on what should constitute a valid endpoint for Crohn's disease trials. Specifically, patient-reported outcomes, according to FDA guidance, should generally be coming from patients and use patient interviews and expert elicitation of what is the primary components of a patient's disease that are important to the content validity of the score. In addition, the guidance states that these outcome measures should be responsive and reliable, and this is not the Crohn's Disease Activity Index. For one, it's not a patient-reported outcome, it's a composite score. So in the face of this challenge, what can be done? First, a new patient-reported outcome needs to be developed. However, the timeline for that is probably greater than a year. Second, there are multiple programs in phase 2 and phase 3 trials that cannot wait. We had great news for patients this past week with the FDA Advisory Committee for vedolizumab stating this could be a treatment soon for our patients with Crohn's disease. We'd like to continue that, and this could be a barrier for other good news for patients. So we need a sensible interim solution, and what can we do? Well, the Crohn's Disease Activity Index diary card does contain items that are patient-reported, such as abdominal pain, a number of loose bowel movements, and well-being. So our proposal is to look at how these items, using binary measures, yes, no, greater than a certain threshold, correlate with the CDAI remission. So CDAI generally goes from 0 to 600. Scores of less than 150 are associated with remission. So then, can we look at other data sources from clinical trials and see these operating characteristics retrospectively, and then again test them in other trials for their validation? So we looked at two trials for this study, a trial of rifaximin and a trial of methotrexate, both randomized controlled trials with outcome measures based primarily on CDAI. Now, there are two phases here I will briefly address. One is developing the cut points for CDAI and which specifically variables were used. This was derived, as I'll show you, from a trial of rifaximin, and generally two PROs that are candidates were looked at. One is pain and stool frequency, and the PRO 3 would be pain, stool frequency, and a patient's general well-being. Then these were tested in a prospective trial of methotrexate, looking at how they would compare to the endpoints in that trial. Now, first, these ROC curves, receiver operating characteristic curves, needed to be developed, and we needed to find the cut points for these 2 and 3 item PROs, adjusted to a CDAI detection of a CDAI remission. So you see here the 3 ROC curves. The area under the curve generally ranges from about 0.8 to greater than 0.9. The cutoffs were a loose stool frequency, mean daily score less than or equal to 1.5, an abdominal pain score less than 1, a mean daily score, and a general well-being score less than or equal to 1. Next, so looking at the National North American Crohn Study Group investigators' study of methotrexate therapy for Crohn's disease. This study was a study of patients who were at least on 3 months of prednisone and then tapered, randomized to methotrexate and placebo. Here, the primary endpoint was Crohn's disease activity index less than 150 and a steroid-free remission. You see here the difference between placebo and methotrexate in the trial. Placebo remission rates of around 19%, and methotrexate remission rates at 39%. About 50% of patients in this trial had an elevated acute phase reactant called oromucosoid, which is similar to C-reactive protein. So going through effect size at week 16, specifically here, we'll look first at using traditional outcome measures, Crohn's disease activity index less than 150, a steroid-free remission, Crohn's disease activity less than 150 and no acute phase reactant elevation, and then the trifecta of remission, prednisone-free, and normal oromucosoid. And I just direct your attention to the effect sizes here. So generally in the total population, the effect size or difference between methotrexate and placebo was generally 15 to 20%. If you look at the population with elevated inflammatory marker at baseline, the rates range from about 15 to 28%. Now the question is, how well do these 2 and 3 item PROs correlate with these outcome measures? Now if we look at the PRO2, which would be pain and stool frequency, we see here very similar effect sizes of about 15 to 20% regarding patients who have no oromucosoid or acute phase reactant elevation at baseline. And then again, you see effect sizes of 13 to 25% in patients who had an elevation of their acute phase reactant. So very similar as you previously saw here in the last table. If we look at a 3-item PRO, it's actually very similar to this as well. You see generally this 15 to 20% effect size in both populations, and looking at across the endpoints between a PRO3 alone to the trifecta again of remission by a PRO, normal oromucosoid, and no prednisone. These measures also correlate well generally with changes in the CDAI. So in conclusion, patient-reported items on the CDAI diary card, particularly stool frequency, abdominal pain, and general well-being, may have value of an interim 2 or 3 item patient-reported outcome measure. Similar treatment effects, as you saw, were found with these 2 and 3 item PROs compared to the CDAI in the trials of methotrexate, and can be looked at in additional studies. The largest treatment effects were seen when patients were subset or sub-analysis of patients who had definition of remission in the population was restricted to patients with objective markers of inflammation, such as the elevated acute phase reactant. So there needs to be ongoing research to determine the potential utility of PRO2 and PRO3 instruments as outcome measures for Crohn's disease clinical trials. We don't see this as the only measure that can solve this challenge or barrier to Crohn's disease trial progress, because this doesn't address the problem necessarily of high placebo rates and the lack of correlation between patient-reported outcomes and objective measures of inflammation. However, this, in conjunction with a co-primary endpoint such as endoscopy or MRI, may be effective tools at overcoming this challenge and providing our patients with effective new therapies in the years to come. So thank you very much.